Alright, hello everybody. Today we're going to be going over varus and valgus testing, so looking at the ulnar collateral or medial collateral ligament, as well as the radial or the lateral collateral ligament. So what we're going to do is we can have our patient laying in supine here, and I'm going to take his arm here, bring him into about 20 to 30 degrees of elbow flexion, and from here, what we're going to be doing is we're going to be kind of stabilizing at the humerus, and then using that to help us provide a valgus force. And that would be for a valgus test. And then similarly, we can also stabilize at the distal humerus, and we can use the forearm and the humerus to provide a varus force. And that's going to be testing more of the radial collateral or lateral collateral ligament. With either of these, what's going to be considered a positive is either A, if they have a lot of excessive laxity compared to the other side, or if they're getting a reproduction of their pain or symptoms when you're doing that testing. Alright, so the next test that we can do is called the milking maneuver. So this is going to be testing, again, the ulnar collateral ligament, but this time it's going to be doing more of the posterior band, because what we'll be doing is bringing our patient into about 90 degrees of elbow flexion. And then from here, what we can do is we can take a hold of the patient's thumb, and we're going to be providing a valgus force. And what we're looking for here, again, is if they either have an excessive laxity compared to the other side, or if they're getting a reproduction of pain or symptoms. All right, so the next test that we'll be going over is the moving valgus stress test. So again, looking at the ulnar collateral or the medial collateral ligament. So what we're going to do is have our patient sitting here. I'm going to come around behind you here, Josh. And what I'm going to do is I'm going to have the patient go ahead and come up into about 90 degrees of abduction. I'm going to bring them into maximal flexion. And then from here, what I'm going to be doing is kind of using their humerus to push them into some valgus, and as I'm doing that, I'm going to be pushing them from full flexion into more of extension. And what we're looking for here is if they're going to get a reproduction of their pain or symptoms, and generally that's going to be between 70 to 120 degrees of elbow flexion when they're going to have that reproduction. So next we're going to be going over a cluster of tests used for lateral epicondylitis. So this is going to be the Cozen's, the Mills, and the Molly's test. So what we're going to be doing is have our patient sitting here, and they're going to be saying likely they're having complaints on the lateral side of their elbow. So what we can do is we can have our patient hold our arm like this. We're going to have them bring their arm into a fist, and then we're going to go up like so. And I'm going to be providing resistance downward from extension. And if they say that they get pain, that's going to be a positive if it's reproducing the same pain that they've been having. Similarly, the Mills test is going to be basically the opposite of this. So I'm going to go ahead and support your arm here. I'm going to keep them kind of in that fist formation. And then I'm going to bring them back like this, and you can see some apprehension on his face. So basically we're shutting down all of those muscles, lengthening them out. That is also going to be a positive if it reproduces their pain. And then the last one that we can do is going to be our Molly's. So our patient is going to have their hand straight out like so. And then from here, I'm going to be providing resistance downward on the middle finger. And we want to make sure that we're past the PIP. So I'm going to push down here. And if he has any pain reproduction in that same area, then that's going to be a positive as well. All right, so next we're going to be going over the biceps rupture test, or bicep squeeze test, which is looking for a rupture. So what we're going to do is we're going to have our patient sitting, and then from here I'm going to have exactly like he is actually. I'm just going to have him rest his arm on his thigh. We want the elbow to be in about 60 degrees to 80 degrees of flexion, so about right here is right. And then all I'm going to be doing is providing a good squeeze on the bicep, and I'm going to be watching his hand motion. What I'm looking for is if he's going to get basically a degree of supination. If I can see that it's going into some supination, then that would be a negative because it means that his bicep is working. If I don't see any movement at all, then that's going to be a positive. You see a little bit of supination there, so that would be a negative, which means that the bicep is not ruptured. We're all good. All right, so next we're going to be going over a test that is looking for specifically the ulnar nerve and really in the cubital tunnel. So what this is called is the elbow flexion test. So what I'm going to have you do, Josh, is I want you to come up kind of like you're serving some hot food up on your both sides. Perfect. And we're going to have the patient basically stay in this position for up to 3 minutes, and we're looking for a reproduction of their symptoms, so any numbness or tingling that's going to be coming out. One thing that we can do if we want to further sensitize this same test is, Josh, I'm going to have you come from here, and we're going to add some abduction. So you're going to come up like this for me, and then similarly looking for if they're going to have that reproduction of symptoms coming down their arm. And that's all. All right, so the next test that we're going to go over is again going to be for the ulnar nerve, specifically in the cubital tunnel. So what I'm going to do here is I'm going to go ahead and take control of Josh's arm here. Go ahead, relax, relax, relax. So I'm going to have him in some abduction here. And all I'm going to be doing is I'm going to be giving a tap right onto where the cubital tunnel is, right behind the elbow here. So and all I'm looking for is if he's having a reproduction of his symptoms, reproduction of his complaints, because this is something that may oftentimes cause a little bit of that numbness and tingling. So we want to make sure that it's the same thing that they came in with. All right, and then another test that we can do is going to be the pinch grip test. So this is going to be looking at the anterior interosseous nerve. So what we're going to do here, Josh, is all I want you to do is go ahead and bring your arm up, and I want you to make an okay sign, like everything is all good. And I'm looking for if he's able to maintain this tip to tip. So are you able to almost make that a little bit rounder? Perfect. And we're looking for that tip to tip, straight tip to tip on each of those fingers. And if we do see that they start to kind of flatten out here, so it almost turns into more of a teardrop, or if they're getting some different motion coming through their thumb, then that's going to be significant of a anterior interosseous nerve problem because they're unable to maintain that positioning. So if we see that teardrop sign coming, that's going to be a positive. All right, so a test that we can do when we're looking at instability in the carpal, specifically at the scaphoid, is going to be the Watson test. So what we're going to do is, Josh, I'm just going to have you go ahead, face me just a little bit. I'm going to take your arm here. And what we're going to be doing is we're going to be taking our patient, we're going to put them into some ulnar deviation and some slight wrist extension. From here, go ahead, give me a thumbs up. I'm going to come to the scaphoid, and all I'm going to be doing is giving a dorsal force to the scaphoid while also pulling them into some radial deviation as well as flexion. And what I'm looking for here is if you either get a pop, a click, or a reproduction of the symptoms, and that would be a sign of a positive test. All right, so two other tests that we can do when we're looking at carpal instability. We're going to be looking at the scapholunate shear test as well as the lunotriquetral shear test, so looking for instability between the two. So what I'm going to do here, Josh, is I'm just going to go ahead and I'm going to find the scaphoid first. So go ahead, give me a thumbs up. Perfect. I'm going to come up top here, and I'm going to follow down and come down to the capitate, come a little bit proximal, a little bit ulnar, and I have the lunate here, and now I'm just going to be giving a shearing force between the two here. And we're looking for a reproduction of the patient's symptoms or a hyperlaxity compared to the other side. From here, what I can do is, since I already have the lunate here, I'm just going to come right on top with my other hand, And then I'm going to come over to the pisiform. And that way, I know that I'm on the triquetrum. So I'm going to go ahead and give the same shearing force here. And again, I'm just looking for if the patient's going to have any reproduction of pain or if it's going to be a hyperlaxity compared to the other side. And that would be considered a positive test. All right, so another test that we can do is the Lightman test, also known as a midcarpal instability test. So what I'm going to do here is, Josh, I'm going to go ahead and feel your hand here, and I'm going to be coming down to his capitate here. And then from here, I'm going to be putting him into some radial deviation. And then I'm going to be giving some compression down onto the capitate. And from here, I'll be bringing him into ulnar deviation. And what I'm looking for here is if I'm basically going to feel the instability. I'm going to feel that the proximal row may be popping out at me almost, which would be a sign of a positive test. All right, so the next test that we can do for a instability is going to be the shuck extension test. So what we're going to do here is you're going to have your patient basically rest their arm onto the table. I'm going to have you, if you can, I want you to bring your fingers like this for me. So we're going to bring him into some MCP flexion. And then from here, I'm just going to be applying a resistance for him. And then I want you to push up against me here. And what we're looking for is if the patient is going to have a reproduction of pain. So if they get a pain as they're going through that extension against you, then that's going to be a sign of a positive test. Alright, so two tests that we can do when let's say a patient comes in with some radial sided pain and we want to figure out if maybe the first CMC is involved. One test that we can do first is going to be the axial load. So all I'm going to do is I'm going to take your thumb here, I'm going to be taking the thumb, and I'm going to be applying an axial compression. You alright? Okay. Applying an axial compression into the CMC. And then from there, if I don't get any positive result, which would be a reproduction of pain, then I'm going to, again, continue the axial load, and then I'm going to be providing some circumduction here and looking for if they're having a reproduction of their symptoms, or also if I'm suspecting arthritis, if there's going to be any crepitus or clicking that's going to be going on in that CMC. So if we're suspecting that there is some sort of loss of integrity in the distal radial ulnar joint, one test that we can do is going to be called the piano key test. And all you're going to do is you're going to find the ulna here, and we're just going to be pushing down like a piano key. And we're looking for if it's causing any reproduction of the patient's pain or symptoms as we do that. Another similar test that we can do is going to be the distal radial ulnar joint stress test, or also known as ballottement. So all we're going to do here is we're going to take the patient's ulna, and then we're going to take the patient's radius at the distal end, and we're going to be applying a shear to each of these, and we're looking again for a reproduction of the patient's symptoms or reproduction of their pain. So one more test that we can do when we're looking at the thumb is if we're suspecting that there is a possible UCL issue, then we can do the UCL stress test. So what we're going to do for this is, Josh, I'm just going to take your hand here, and I'm going to take his thumb, going to put him in about 20 degrees of flexion, and then from here what I'm doing is I'm going to be providing essentially an abduction force to the thumb. And what I'm looking for is if there's more than 30 degrees coming from that laxity, that would be with a strain of or a tear of the UCL. So if we're above 30, then we can, that's going to be a positive, and that's going to be at least a partial tear within that UCL ligament. All right, so if a patient is coming in with ulnar-sided pain and you're suspecting that the TFCC may be a potential issue, then one of the tests that we can do is the ulnomeniscal triquetral dorsal glide. So what we're gonna do for that is I'm gonna take the patient, put them in neutral here. I'm gonna basically come to the pisiform. Now I'm also gonna come around to the ulna here. And all I'm gonna be doing is providing a shearing force between the two and looking for a reproduction of pain. So if they do get the same reproduction of pain or symptoms that they've been having, then that's going to be a positive test. All right, so the next test that we can do if we're looking for or suspecting a TFCC problem is going to be the hand press or the sit to stand test. So essentially, I'm just going to have my patient sit in a chair that has some armrest. I'm gonna have you scoot back all the way in the chair, perfect, and then I'm gonna have you put your hands like this for me, like you're gonna push off, and I want you to stand up, but I want you to push as much through your wrist as you can, only use your legs as absolutely needed. Good. And he's able to get up with no pain. In the event that they do have some pain or a reproduction of their same pain or symptoms that they've been having, then that's going to be a positive test. Another test that we can do if we're suspecting a TFCC involvement is going to be known as the supination test. So you're going to have your patient sitting, and all you're going to do is you're going to put them into some supination. And there's two ways you can do this. Either one, you could actually provide the supination resistance yourself and have them basically try to curl up into you. Or another one is I'm going to have you go that same position. We're going to make sure that they're lined up with their wrist here under the table, and then I'm going to have you push up into the table. Good. And if we get a reproduction of their pain or symptoms during either of those, then that is going to be a positive test. All right, so the last test that we can do if we're suspecting a TFCC issue is going to be the ulnar impaction test, and then the other one is going to be the load test. So what we're going to do is have our patient in sitting just like this, have their arm flexed about 90 so that they're parallel here, and then what we're going to be doing is taking a hold of the patient's hand here, and we're going to be bringing them into some ulnar deviation and loading kind of through the 4th and 5th metacarpal here. And what we're looking for is a reproduction of their pain or symptoms. So that in itself would be one test. And then if we want to further sensitize it, something that we can do is we're going to continue with that load test. So we're going to load in through the 4th and 5th metacarpals, and then we're going to be giving some flexion and extension as we're going throughout that loading. And again, we're looking for a reproduction of pain or symptoms, which is going to be a positive for the TFCC load test. All right, so two tests that we can do if we notice that there is some limitations in flexion at either the PIP or the DIP are going to be the Bunnell-Littler or the Haynes-Zancoli test. So for the Bunnell-Littler, that's going to be for the PIP. So we would have the MCP in neutral, for example, and let's say that we go through PIP flexion and there's some limitation there. So what you can do here is you can bring them into some MCP flexion, and then again we're going to test that PIP flexion. Now in the case that they get a little bit more movement, then that's going to tell you that this is more of a intrinsic problem, like ligament problem, that is causing the tightness rather than an actual joint issue itself. In the case that the limitation was actually the same in either of those, then that's going to be more significant of a joint issue. Now similarly for the Haynes-Zancoli, the idea is going to be almost the same. We're going to be basically keeping the PIP in about neutral, and then we're going to be giving some flexion here to the DIP. And if we have some limitation here, what we can do is flex the PIP. And then similarly, we're then going to flex the DIP, and we're going to see if we get any extra movement. And again, if we have any extra movement, then that's going to be significant that it was a tissue problem like ligament or a intrinsic tightness versus a joint problem. However, if the limitation is still the same regardless of those positions, then that's going to be more significant of a joint issue. Alright, so a test that we can do when we're suspecting De-Querc veins or some sort of inflammatory problem within the first compartment is going to be the Finkelstein test. So what we're going to do for this is we're going to have the patient in sitting. Generally you would do this on a plinth table, but I'm working with what I have right now. So we're going to have the patient basically go ahead and cover your thumb like this for me. Good. So once they have their thumb covered, what we're going to do is we're actually going to take them into some passive ulnar deviation. And what we're looking for is if they have a reproduction of their complaints and symptoms of that pain, either coming kind of through the snuff box or through that first compartment. And that would be a positive sign. Alright, so if we're suspecting a problem with either the flexor digitorum superficialis or the profundus, we can do the flexor digitorum profundus or superficialis test. So what we're going to do is we're going to have our patient in sitting. We're going to have you a little bit so that you're almost flat like this for me. So what we're going to do is essentially we're going to be blocking off the fingers, and this is going to be for the superficialis. We're going to block off the fingers here, and then I'm going to ask the patient to go ahead and bring their finger all the way up. Good. And then keep it up for me. And you'll notice that the profundus isn't being used. It's only the superficialis that's firing, which is what we want. So if they weren't able to achieve that positioning, then that would be a positive test. And then opposite for the profundus, we can bring the patient up into some elbow flexion here to help isolate. But what we're going to do is we're going to, essentially the profundus is going to be supplying this deeper branch here. So we're going to block off the PIP and then metatarsal or metacarpal. And then from here, I'm going to ask them to bend that finger. This one. Good. And you can see that she's getting motion coming through that DIP, which means that the profundus is working properly. If she wasn't able to get any movement there, then that would be a positive test. Alright, so another test that we can do if we're looking at the flexor digitorum profundus is going to be the sweater finger sign. So what we're going to do for this is we're going to have our patient put their hand out, and we're essentially going to ask them to make a fist. And all we want to do is see, can you get all the way in? I guess your nails are kind of in the way of it. So once we can see that they're getting that DIP flexion all throughout, then that would be a negative. What we're looking for is if only one of these, the DIP isn't flexing in, or if multiple of them. But if we see that the DIP isn't able to flex, then that's going to be kind of signifying that the profundus isn't firing and isn't able to get it to curl all the way in. So that would be a positive for the sweater finger sign. Alright, so if we are seeing that a patient is having a problem with extending the fingers and we're worried about the extensor hood itself, then a test that we can do is going to be the extensor hood test. So what we're going to do is have our patient basically line their hand off of the table so that their metacarpals are going to be bent. And from here, what we're going to do is we're going to have them extend, and we're just going to be applying a little bit of pressure. You can do this at one finger or multiple. So go ahead and push up against me, straighten your fingers out. Good. And if they're able to and they don't have any pain, then that's a negative. If they have some pain when they're going up and that's a reproduction of their symptoms, then that's going to be a positive test. Alright, so the next test that we're going to do is going to be the Phelan's test. So this is going to be a test for the carpal tunnel syndrome if we're suspecting that it could be a potential issue. So what I'm going to do is have the patient, I'm going to have you basically bring your back of your palms together down here, and then we're going to come up until it gets tight. Good. And then all you're going to do is you're going to have them hold that position for about 30 seconds. And what we're looking for is a reproduction of their numbness and tingling, generally through that median nerve pattern. So if they get through the full 30 seconds and they don't have any issue, that would be a negative. If they do start to get some numbness and tingling and they say that that's a reproduction of what they've been feeling, then that would be a positive test.
I do get.
Alright, so the next test that we can do if we're suspecting carpal tunnel syndrome is going to be the hand elevation test. So, patient, if you could follow my lead, I'm gonna have you raise your arms up overhead. Then we're gonna go like this, like a pretty ballerina, and I want you to hold there for 3 minutes. So we're gonna hold for that position for up to 3 minutes, and what we're looking for is a reproduction of their either numbness and tingling or any pain that they're having through that carpal tunnel or median distribution. And if they are able to get through the 3 minutes, you can go ahead and relax.
I feel tingly.
And if they get some numbness and tingling, that's positive. If they don't, that's a negative. Alright, so the next test that we can do when we're looking for carpal tunnel syndrome is going to be the carpal compression test. So what we're going to do is we're going to have our patient lay their arm out. We're going to put them in some supination. And what we're going to do is we can use both fingers here. We're basically going to give some compression to that carpal tunnel. And we're just going to hold here for about 30 seconds. And what we're looking for is if they get a reproduction of their symptoms. So if they say that they're having the same numbness and tingling or the same pain that they've been having, then that would be a positive test. If they don't get anything, that's a negative. Alright, so the next test that we can do when we're looking at sensation for the carpal tunnel syndrome is going to be the Weber's-Mobert 2-point discrimination test. So generally, you're going to want to use a 2-point discrimination wheel that has the different millimeters. Today we're using this because we don't have one. And what we're going to do is we're going to have our patient put the hand over here. And all you're going to do is you're going to generally use the 2-point discriminations and the 1 point to ask your patient to either close their eyes or use a piece of paper to block what they're seeing. So that you're going to be testing, saying, do you feel 1 or 2 points?
Are you asking
Do you feel 1 or 2 points?
2?
2 points, okay.
Sorry.
And then you would switch it up and go through 1 and 2, and you want to make sure that they can feel at least a 6 millimeter difference as you're going throughout that. If they do have more than 6 millimeters, then that is going to be a positive, and you also want to be comparing this to the uninvolved side to make sure that it is a specific problem to what they've been complaining on the involved side. Alright, so the next test that we can do when we're looking at carpal tunnel syndrome is going to be the reverse Phalen's. So pretty similar to the Phalen's, just going in a reverse motion. So what we're going to do is I'm going to have you basically come like this for me, and then we're going to bring our arms down like we're praying. And then we're going to be holding this for up to 60 seconds. And what we're looking for is a reproduction of their pain and symptoms. So if we're getting any numbness or tingling going throughout that median nerve distribution, if they do not get anything, then that's going to be a negative. Alright, so the next test that we can do when we're looking or suspecting carpal tunnel syndrome is going to be the Tinel sign at the wrist. So what I'm going to do is I'm going to have the patient come into supination. And what we're going to do is we're going to come right over the median nerve. And all we're going to do is we're going to give a series of taps. And what we're looking for is if they're having any complaints of any reproduction of numbness or tingling throughout that median nerve. If they do get a reproduction, that's going to be a positive. If not, that'll be negative. And then something that you can use either subjectively or during examination is if they have complaints of that numbness and tingling going throughout the median nerve, what we can do is we can do the flick maneuver. So whether they tell you that maybe they've been having that numbness and tingling and the only thing that they can get it to go away is to go like this, or if they have a reproduction of the symptoms while you're in examination and you ask them to go like this, and that's going to make it go away, then that's going to be a positive. Obviously, if not, that's a negative. Alright, so a test we can do when we're looking for ulnar nerve, if we're suspecting that ulnar nerve is an issue, then we can do the Froment sign. So what we're going to do is we're going to take a piece of paper and we're going to place it in between our finger, our patient's thumb and their index finger, and they're going to be holding it like this, using their adductor, and then from there you can give it a slight pull. And if they're able to hold without any compensation, that would be a negative. What you're looking for a positive is if they get some hyperextension at the MCP and the carpal, and then if they're getting some IP flexion, basically trying to compensate to get onto that paper. Go ahead, let go. and that would be a positive sign. Alright, so a test that we can do if we're suspecting or we just want to check the integrity of the vascular system is going to be the Allen test. So what we're going to do is we're going to have our patient put their arm out, we're going to put them into some supination, and we're going to come to their ulnar artery and their median artery. And what I'm going to have you do is I'm going to have you clench your fist 5 times, and on the 5th time I want you to stay closed. And we're going to do that 1 time, and then we're going to repeat it afterwards, okay? So I'm going to be giving some compression here on their arteries, and then go ahead and clench your fist 5 times. Hold on the last one. Good squeezes. Good. And then from here, go ahead and start to release your hand. I'm going to come off of the ulnar artery, and what I'm looking for is that I should see a gradual flow through the ulnar artery coming back into the hand with the blood flow. And I'm going to repeat the same thing here. So we're going to go ahead and give 5 clenches. Hold, good. And then from here, I'm going to let off of the median artery, and then go ahead and relax your hand here. And again, we're just looking to see if that blood flow is going to come through the median artery, back in through the hand, while we have the ulnar blocked off. So what you're looking for is just if you're going to have any either unevenness, any change between the two, or if there's just a really hard time or extended time to fill on either of those.